Hey, good morning, everyone. Let me know if you can hear me okay. Start here. A couple questions to go over. Someone can just keep up if they can hear. Appreciate that. Just make sure everything's working. Oh, perfect. All right. Again, remember, even if you're sitting in the classroom, you can still pop in on your computers and chat along with us. I want to encourage everyone to participate as much as you can. Hello. Hello. Plus, it helps my viewer count if you guys log in. That helps me, send YouTube charts. That can be an internet sensation, perhaps. We're gonna start in about a minute here. We're gonna finish up the GI section with the inflammatory bowel disease, and then we'll get into rheumatology. So that'll be a good segue to that for the week. All right. Well, it is 8 o'clock. Start recording here, and I had a few questions that came up. First of all, so someone was asking, when discussing prokinetic drugs and their ability to increase motility upper GI tract, is the goal to get contents moving to prevent them from being stagnant / refluxing? Yes. So, especially when you see patients with impaired motility issues, like some kids will have this. You'll see patients with like diabetic gastroparesis. Things are just sitting there in the stomach and they can't move through, so they just kind of sit there and they can have a chance to reflux, and so that's why we can help out with that. They also asked, is it correct to think of them like laxatives for the upper GI tract, but they won't affect intestines as much as the esophagus, stomach? Yeah, they're probably not going to affect the esophagus necessarily, although they could have some ability to maybe. I don't even know if they have like a ton of effect on the lower esophageal sphincter as much as it is like kind of the sphincter heading into the small intestine and into the colon. So small and large intestine are the primary places where those are going to be for sure. Yeah, anytime you just need to get things moving along, not necessarily for constipation specifically, then yeah, you can use those prokinetic agents like Reglan or erythromycin. Someone said, just to be clear, H2RAs are safe for use in pregnancy. Generally speaking, yes, they are. I'll talk more about that in the OB-GYN section later on. So, but I probably won't be asking questions about that specific test. Someone said, for the ARCS assignment, should we use the sheet from last semester or should we do the hospital format as you mentioned last week? Just wondering. The link should have the full rubric. So if I attached the rubric to the assignment, I did so for the new one as well. If you scroll down to the second half of that, that's where all the medication order That's where that blank sheet is. So if you don't see that, let me know and I can review it and try to upload it. Remember, your first assignment's going to be due on the 12th. I'll get that, get some feedback to you guys on that, and then the next one will be due on the 26th, even though the second one is available as of this week. So FYI on. And then someone said more of a drug named Linzess for treating chronic constipation. Wondering if we can go to the mechanism of action and when to prescribe it. I actually had to look this up because I'm not familiar with the drug. Not one we especially use in pediatrics, but anyway, so just to show that I am not all knowing, there are still things that I need to look up, and I do so on a constant basis. So I found it's this drug called linaclotide, and I was really unfamiliar with it, but I went ahead and looked at the mechanism. And again, if you have a good understanding of physiology and pathophysiology, it's easier to understand new drugs when they come out. So this one here agonizes guanylyl cyclase C on the luminal surface of the intestinal epithelium. So basically, what that's going to do is when you activate that, it's going to cause more guanylate cyclic GMP to be formed. So guanylate cyclase is an enzyme that converts guanosine monophosphate into cyclic GMP. So once it does that, it actually causes increased secretion of chloride and bicarbonate. So that increase in the osmotic content of the large intestine will cause defecation to occur. That's the goal, at least. Very similar to how if you put like a large osmotic load, like a sodium phosphate enema, into the colon, that causes stimulation of peristalsis and defecation to occur there. So the question is like, when do you use it? Well, I had to ask that too, because I never really see it being used. It doesn't seem like something used for routine constipation, or more like, sort of intermittent constipation. So I went ahead and go to Up to Date. You guys should have some access to this, I imagine, through your library. If not, there's other resources like Dynamed that are out there, but this is an article about the management of chronic constipation in adults in so anyway, so they talked about pharmacologic therapy, and this is a newer drug. It only came out in 2012, which seems like ancient history, but in drug time, that is still relatively new, still brand name only, and found that it's better than placebo, which is good, but we don't necessarily have head-to-head trials saying when it's better than another agent. But they were saying that basically we don't really know what the long-term benefits and risks are, so there's not a full theory as to like when you're supposed to use this drug as opposed to something else. So I'd say for more chronic constipation, if you had someone who is maybe not responding to more conventional therapy, you could try giving this one a go and see how it goes for your patient. I looked at it's relatively cheap, so as compared to some other things. But anyway, that's the answer to that question. And if you have other questions, feel free to post them up. You guys are usually about doing that, especially between the weeks, so I like that. Anyway, we're going to finish up on our GI section here. We're covering the inflammatory bowel disease. Anyway, so the primary things we're going to be focusing on here is going to be ulcerative colitis and Crohn's disease. Main difference here being the ulcerative colitis mainly affects the colon, versus Crohn's disease can be much more diffuse. It can be affecting most sections of the GI tract there. You can kind of see the general breakdown, how it's going to be sort of all over the place in terms of where it's affecting things. This is important because it's going to dictate which type of medications we can use and which dosage form specifically, in order to make sure that the drug we're using is going to be treating the inflammation where it actually resides, right? And so basically, as we mentioned, you're going to have the host immune system sort of inappropriately reacting to the person's tissue and the normal flora and things like that are there within the GI tract. And so that leads to a lot of inflammation. That can lead to damage to the tissue, can lead to pain, can lead to constipation, diarrhea, all kinds of issues that can pop up from this, because the issues in terms of like stress can be related to this too, where someone with Crohn's disease, or you see that they get stressed out just due to general life. This can exacerbate the condition because there's a lot of communication between your GI tract's neural system, basically nervous system, and your CNS. So overall, what we're going to be focusing on is trying to decrease that inflammation as best we can, with some methods we've already seen, but also some new ones that we'll get into. But as I mentioned, like, this is gonna be really severe. In some cases, you can have bowel perforation in severe cases. So ideally, we'd like to limit this as best we can. You're gonna find issues with nutrition sometimes with these patients because they may have malabsorptive disorders due to that inflammation. So lots and lots of issues that pop up from this. But I want to focus on the therapeutic options here. So for ulcerative colitis, we're going to be talking about our aminosalicylates. Now, when I say topical here, this is going to be a little misleading. When you hear topical, you probably think applied to the skin. Not really what we're talking about. We're talking about like applied directly to the GI tract. And I kind of square that, or I guess around that square hole egg. I can't remember the saying right now. But basically, if you think about a person, you yourself are just one long giant tube from from top to bottom. Maybe you can think about the GI tract as sort of a topical thing that just happens to be on the inside of you. Hopefully, never comes to the outside. But regardless, so when I say topical, it means like drugs that are either applied rectally or directly to the GI epithelia. So we'll talk about those options there in a little bit. Oral options also will be available here. So topically administered drugs in this sense will be typically administered rectally. So we'll get into that in a few moments. So we'll have the aminosalicylates. We'll have our corticosteroids, which with any rheumatologic condition we're going to see, or autoimmune condition, this will be a cornerstone of therapy. We'll see in a little bit. And then we'll have some immunosuppressants. We'll have a few monoclonal antibodies that can help to suppress that inflammation. Talk about some miscellaneous things like probiotics and surgery and things that we're not going to get too in-depth on, mainly because they lie outside of the scope of this course here. We'll find with Crohn's disease, it is largely treated the same, although there are some roles for antibiotics to play. Patients with Crohn's disease tend to have more of a likelihood to develop some of these like small intestinal bowel growths of bacteria that need to be treated. They can develop abscesses and things like that. So there are a role for antibiotics. And we'll look at a few antidiarrheals, which we already covered some last week. Our goals here are to try and resolve that inflammatory process, as we mentioned, and try to resolve any complications, like developing things like perforations, fistulae, abscesses, etc. And then also sometimes you'll find they can actually have extra intestinal manifestations. They can have other things affecting the body. And interestingly enough, you'll find some of these patients that have one autoimmune condition, they may have a risk for developing other autoimmune conditions. So I remember one patient who had Crohn's disease plus type 1 diabetes plus some degree of rheumatoid arthritis. It was kind of a triple threat for that particular patient, just because their body just really didn't like them very much and wanted to attack them, unfortunately. But once we kind of get these effects under control, then we want to have maintenance of remission, hopefully, and try to, you may see some cases resolve on their own, but in a lot of cases they require more indefinite therapy. So we'll look at some options for that as well. Okay. So starting off with our drug therapy options here, we have sulfasalazine, or azulfadine is a brand name here. This one is again, most of these are going to be orally or rectally given. I'll try to make those distinctions here in just a little bit. The dosage form does matter, and I'll show you where that comes into play here in just a few moments. Basically, this is a prodrug. If you recall, prodrugs are drugs that are inactive in their original state, but have to undergo some sort of metabolic process in order to become active. In this case here, it's actually the colonic bacteria that do the work for us. We're putting those little freeloaders to work here and converting sulfasalazine into sulfapyridine and 5-aminosalicylate, or mesalamine. This is going to be a drug that will come up here in the next slide or two. So 5-aminosalicylic acid, so it's kind of an aspirin-like derivative. We already know aspirin to be an anti-inflammatory. Will help to reduce that inflammation by inhibiting enzymes like cyclooxygenase, lipoxygenase, etc. So overall an anti-inflammatory action here. In terms of adverse effects, the main things you're going to be seeing include things like anorexia, diarrhea. Patients may be experiencing that already, so sometimes it's difficult to tell, is it the drug, is it the disease, which one's kind of worsening here, but these are things that are commonly reported. You do want to monitor the CBC for this because you can see some issues of light immunosuppression, so you may want to look at their white counts, platelet counts, etc. Make sure that nothing's going wrong there. Then we just have regular mesalamine itself, so instead of getting that sulfapyridine, maybe you have a patient who has a history of like a sulfa allergy and you did not want to give something like sulfasalazine. you could generally utilize mesalamine by itself. And again, same mechanism, just does not undergo that metabolism process by the colonic bacteria there. Generally speaking, there's fewer side effects because you're missing that sulfapyridine aspect of the drug there. So some people may prefer this over sulfasalazine, although I've seen both used, so it just depends on the provider and the patient, kind of what they tolerate. A lot of the products here are going to be designed to deliver mesalamine to the colon, where it actually does not get absorbed. That's a good thing because if you can limit systemic exposure to drugs, that limits the systemic side effects that you can develop. So that may be a benefit to some of these products here. I just mentioned the different brand names because I wanted to focus on the different dosage forms that we have available, and so this will be important depending on whether your patient has ulcerative colitis or Crohn's disease. So for instance, if I have something that I'm taking orally, there's a very good chance it's going to interact with every surface of the GI tract from top to bottom, right? So for someone that has more diffuse disease, such as Crohn's disease, that's a good thing. They can get away with using oral products and it hits everything. However, if I wanted to limit exposure even more specifically, what if I had a patient with ulcerative colitis that only affected, say, certain parts of the colon? Well, then if I could get away with something like a rectal enema, for instance, then that could be beneficial. So for instance, here's one called Kinase, which is basically a suppository that's going to be used per rectum. It's a PR there. This would be good just for proctitis because are you inserting the medication? Well, right there into the rectum. So this would make sense that it would work just in that particular area there. Or in the case of an enema, you may be able to use that to get a little bit deeper into the colon from the rectal route. And so, for instance, here you could use enema at 60 ml, so about 2 ounces, for more left side disease. We'll typically find that this is as far as you can get with rectally administered drugs, just due to gravity and due to the GI tract itself, that it's going to be more difficult to get that. So for someone who has a more involved colitis and maybe affecting, more of the right side, or the entire colon, rectal medications may not be effective because it just won't come into contact with that tissue. So in those cases, they would need an oral option in order to come into contact with those surfaces. So think about where the actual inflammation is and how, if you can tailor the dosage form just to hit that one particular set of tissues. Otherwise, that helps to limit the side effects because you're only getting so much contact with the tissue. Otherwise, if it's oral, it's more likely to be absorbed and you're going to, you'll see more systemic side effects. This is a good kind of graph to show you where the site of action would be for particular dosage form. So for instance, a mesalamine suppository is really only going to be able to come into contact with the rectum. Whereas if you're utilizing an enema or something like that, you're going to be able to get more of the distal colon. Some of these products tend to be more of like a delayed release product. If you look on this last slide here, you can see a DR capsule. That stands for delayed release. They're designed to open up and release the drug at a later portion of the GI tract. And so for instance, something like this, like Basalazide or something, would be more of the proximal colon on down. And then something just taken orally that's immediate release would be able to affect the entire GI tract. So from the jejunum on down, so something like Pentasa here. So depending on where the inflammation is, it's going to dictate which dosage form you're going to use. If it's just a proctitis, then I can use a suppository, but this would be ineffective if I had something that, like Crohn's disease, that was affecting most of the GI tract. That makes sense. All right. Some other options here, we have osalazine, which is basically a dimer of mesalamine, meaning it's just 2 molecules of the drug put together. It's also a prodrug that has to be cleaved in order for it to become activated. And then Basalazide is another option here. It's a prodrug. Basically, is the mesalamine, the 5-ASA, plus this inert carrier molecule that just kind of gets defecated out once it's been metabolized. So a few different options, not to say that one's more effective than the other. It just depends on what the provider preferences are and how the patient tolerates it to figure out which one you're going to use. Another option we have available to us, just like we've seen with other conditions, like we saw with pulmonology and things like that, if you want to knock down the immune system, corticosteroids are going to be the way to do it. We know there's a lot of different anti-inflammatory effects. They're going to suppress immune cell reproduction. They're going to inhibit production of prostaglandins and all those sorts of things. So very good anti-inflammatory drug. I'm going to focus more so on the options we have here in terms of dosage forms. We're going to see there are topical forms that we can give. So for instance, hydrocortisone enemas or suppositories that you can use. Again, that's going to be able to just work locally in that tissue, not get a ton of systemic side effects. You may still see a little bit, but not as much as if you were taking like an IV dose of the corticosteroid as an example. Otherwise, we also have some oral options as well. One that I want to at least make particular note of is budesonide here. This one, if you recall, we talked about in terms of its use for asthma. We also talked about it back in ENT for its use in the nose for rhinitis. Things like prednisone, methylprednisolone, they get absorbed from the GI tract pretty easily, and they can have systemic effects, which are good for flare-ups and things. However, budesonide is kind of interesting because it has really extensive first pass effect. And if you recall, that's where the liver can metabolize drugs and maybe limit how much systemic exposure someone has to the medication. This one has really extensive first pass, meaning that whatever does get absorbed from the GI tract is going to have very limited systemic exposure because all of it gets metabolized in the liver. So budesonide is a really good oral option that patients could take chronically because it has very little systemic side effects as opposed to something like prednisone. That's one really good option there where it'll work locally in the GI tract, but not systemically. So that may be used for chronic use. However, for flare-ups and things like that, we may require some of the more systemically active drugs in order to get that inflammation under control. So things like prednisone, for instance, or for more severe cases, more severe flare-ups, this is where we're going to use IV medications like prednisolone, methylprednisolone, dexamethasone, hydrocortisone. All these options here are totally fine. Be aware of some of the more chronic issues you're going to run into from use of corticosteroids, things like weight gain, diarrhea, glucose intolerance. You can see increased glucose levels with that, osteoporosis. A lot of these things can be mitigated by using the shortest course possible of the corticosteroid. And in general, for the systemically acting ones, I will tell you the main goal is to try to get them off of those as best you can. And so we're going to see when you're kind of going through the different options as treatment, you can scale up and scale down in terms of how much inflammation is actually happening. Typically, getting them off of the systemically active corticosteroids is your first bet. So if you can get them off of oral corticosteroids like prednisone, that's always the first thing you should be doing, okay? Budesonide is going to be an exception to that. They can be on that more chronically. Things like topical hydrocortisone, they can be on that more chronically. So those would be the exceptions to that particular rule. And we have some immunosuppressants that are going to be good for more the long term. These are things that may take several months to kick into play. So things like the mesalamine, things like the corticosteroids, they're going to be working much more quickly. They're going to have anti-inflammatory actions pretty quick there. The immunosuppressants are better for more sort of long-term suppression of inflammation that may prevent flare-ups in the long term. So we have things here like our Thyropirins, which I think we talk about oncology this semester. So we haven't covered these drugs just yet, but there's some that actually work by inhibiting production of new DNA. And so this is going to be primarily affecting really rapidly dividing cells, which include things like your white cells, right? So by this means you're able to inhibit inflammation because you have less white cells to cause inflammation. And so, for instance, you have things like azathioprine or 6-mercaptopurine. These can take months to kick in, right? Because it doesn't deal with the inflammation immediately. You still have all those white cells that are currently there, but it's going to be affecting their replication in the long term. Even though they may experience side effects right away, doesn't mean the drugs are going to kick in for the therapeutic effect until much later. So, to have them being treated, symptomatically with other things in the meantime, like corticosteroids, until these drugs have time to kick in. In terms of adverse effects, you can find some flu-like symptoms associated with these two in particular. Myelosuppression, so secondary risk for infections is huge with these ones. So definitely watch out for that. Make sure people are washing their hands and using their mask and all kinds of stuff like that, especially if they're on myelosuppressive therapy, because they are a particular risk for developing secondary infections. Some other options you may use occasionally: Lewcyclosporid. This one actually inhibits release of interleukin-2. And interestingly enough, you also find these drugs used a lot in transplant medicine, mainly because when you transplant someone's foreign tissue into a new person, their body wants to react against that. It looks at it as foreign, which is a lot like the autoimmune conditions we're dealing with here. So by using immunosuppressive agents like cyclosporin and azathioprine, you can actually prevent organ rejection. And so you'll see a lot of crossover here amongst these autoimmune conditions and transplant medicine. So in case you're ever interested in that. Cyclosporin actually inhibits the release of interleukin 2, so that helps to prevent less T cells from being activated. In this one in particular, you can find nephrotoxicity, so I would definitely monitor the renal function and look out for infections and monitor blood pressure because this can cause hypertension. And then a drug we're going to talk more so about next in the rheumatology section is methotrexate. This one is used in Crohn's disease pretty commonly. This one's going to be a folic acid antagonist, and I'll talk about the mechanism in the next section here, so don't get too worried about that just yet. This one you have to monitor liver function. It can be pretty tough on the liver, so you would look out for that. And again, secondary infections due to myelosuppression are relatively or something to be aware of, right? Not to say they're super common, but just be aware that the risk is increased. So some other options we have here as well include some monoclonal antibodies. These tend to be very specifically targeted against one very specific antigen. So in this case here, infliximab is designed to go against tumor necrosis factor alpha. Adalimumab is similarly a TNF alpha blocker. These are probably the most common ones you're going to see being used for Crohn's and ulcerative colitis, although there will be more that are out there. This is a rapidly developing market, and you're going to find all kinds of mAbs, especially if you ever, and I don't know if you guys do this, but whenever I go to my parents' home and they're watching TV, I'm always flabbergasted by how many drug commercials there are. I don't watch TV normally, I just stream stuff online, and so I never see those commercials, but they're everywhere, and there's always like new monoclonal antibodies that are coming out for specific conditions. So this list is huge. I'm only going to get into the really common ones that you'll see on a routine basis. If you'd like to delve deeper, you certainly can, or if you have questions about them, that's fine. The monoclonal antibodies, these are proteins, so they are injectable products. So that is notable there. For instance, with infliximab, people have to come into the infusion center to actually have that infused. Whereas with something like adalimumab or Humira, it's an injectable pen. They can just use that sub-Q at home. So there's some different utilities there depending on how people can administer that. Some of this has to go with worries about things like infusion reactions, because again, you're injecting a foreign protein, so your body could have a reaction to that. So that's something you want to be considerate of. Also note here the dosing, not that I'm going to get into dosing specifically, but the other benefit for these drugs are their long half-life. So for instance here, when you're on maintenance therapy with Remicade, you don't have to do it every 8 weeks. So every 2 months, you'd have to go into the infusion center or somewhere to get this infused, as opposed to taking something every single day, for instance. So that could be one benefit from a compliance standpoint. In terms of adverse effects, things like secondary infections are big for these ones because they are quite immunosuppressive. Note here that you do want to check these patients for tuberculosis beforehand. The risk is that if they have a latent TB infection, when you suppress their immune system, it has a chance for that TB to activate and cause active tuberculosis, which is not something you want for your patients. So usually in the workup for these patients, they're going to get tested for TB anyway, but certainly this is something you definitely wanted to do. And it's a big black box warning for these drugs. And you don't want to be the one that accidentally gives it to them and they had latent TB and didn't test for it, because that'll be a big medical legal fiasco for you to deal with. Also note here that they can have CHF exacerbations. So if a patient has a history of that, that could be a concern there. And there's some small risk for things like secondary malignancies, although we probably don't have the full story on that just yet, since these drugs are still relatively new in the grand things. There's probably some utility in having probiotics on board. The main idea here is that they're going to be displacing pathogenic bacteria with ones that are non-disease causing. I think for the most part, there is not enough evidence to say definitively which ones you should use, if any at all. Just if you look here, there's so many different options that are available, and it's very difficult to do studies that actually show consistent results or to do head-to-head comparisons between these. So the jury's still kind of out on this, but this may be one option you'll see patients being recommended. Probably unlikely to cause harm for the most part for these patients here. And then as I mentioned with antibiotics, You can get some possible benefits here by decreasing the concentration of pathogenic bacteria in patients that may have some overgrowth. So particularly with Crohn's disease, you won't see this used as much with ulcerative colitis. But you can see here that for patients who have like fistulas in Crohn's disease, this is good where we can utilize drugs that target anaerobic bacteria. So things like metronidazole are good for this. Other things you may see Cipro used occasionally, tetracycline, clarithromycin, just depends on other options, depending on what they're growing, if you can get cultures, things like that. So you may see this done occasionally, but more so for Crohn's than ulcerative colitis. So getting specifically into the treatment here, we can see that for ulcerative colitis, we talked about the goals before, but the main thing here to focus on is that treatment's dependent on that severity and location of the disease itself. So as you can see here, if it's more of a proctitis, something like a suppository is going to be more reasonable to use, as opposed to if it's more of a left-sided colitis, you can utilize something like an enema. If it's beyond the splenic flexure here, gotta use oral options, because if you imagine trying to stick an enema into the rectum and trying to get all that fluid, it's only 2 ounces of fluid, so it's not a lot, all the way around the splenic flexure, past the hepatic flexure. I mean, I guess you could spin your patient around or something. Maybe that would work, but practically not super useful. So we'll just use oral options in cases there. So if you get a test question and it says the patient has just a left-sided colitis, then you could probably get away with topical options. If I said it's the entire colon's affected, then oral options are going to be more reasonable. So I take that into account when reviewing your notes and your questions on the exam. That may make a difference in some cases there, right? So anyway, as you can see here, if you're looking at a kind of algorithm for how to manage these patients here, notice it's a stepwise approach, right? So you're stepping up your game as conditions is either more severe, or if you're failing therapy, you step up your game if need be. But for more mild cases, if you notice here, if it's more distal, right, you can get away with using things like enemas. You can use suppositories. You can utilize mostly your aminosalicylates, like mesalamine, sulfasalazine, or like a corticosteroid, like a hydrocortisone enema, something like that, right? Hydrocortisone is not going to get a lot of systemic absorption if just used rectally. So that makes pretty good sense, like we mentioned there. If it is working, then you can maybe scale back your therapy a little bit. Maybe try to go as the lowest dose that's effective. Maybe get rid of the corticosteroid and just use a aminosalicylate. That would be reasonable there. For more extensive disease, more like colitis, that's where we're going to be utilizing the oral options there, like oral mesalamine, or that budesonide we mentioned. That's good for topical, more for oral use, because it does not get absorbed systemically very much, right? Ideally, if you can get them off any corticosteroids, that's going to be the best. But again, budesonide is a pretty safe one to go with if you need to. So just for more mild cases, if you got to step up your game, if you got to go bigger, this is where we're going to be utilizing things like prednisone or the more systemically active corticosteroids. Note here that this is meant as a bridge to get their inflammation under control. The ideal thing would be to get them off the corticosteroids as quickly as you can, but keep in mind you don't want to leave them with all these terrible symptoms they're dealing with and inflammation. So put them on the prednisone, see how they do, and then if you can start to scale back. Remember, if they're on it for more than a week, you do have to do a taper, and some of these patients may require a taper there. Once you start getting into the more severe cases where they may not be responding very well, that's where you can generally utilize your immunosuppressants. So you can consider things like azathioprine, ricaptopurine. Notice here I didn't cover every single monoclonal antibody, but things like adalimumab or infliximab can be utilized here at this point. So once they've failed the salicylates, once they've failed maybe the corticosteroids, or maybe you're bridging them from the salicylates while they're on corticosteroids, that's where you can introduce the immunosuppressants, right? Because the side effect profile is worse for these, but they're also going to be pretty effective for patients that have failed other therapy, okay? In really severe flare-ups, that's where we're going to be utilizing IV corticosteroids, things like hydrocortisone. Again, as they start to resolve, then you can switch them over to something like prednisone orally, and then eventually get them back to something they can tolerate, so where they can withdraw the steroids and probably utilize an antidepressant drug. Again, the goal is always to scale back if possible based on them getting into remission and them staying there. Once they are really severe, you may require things like cyclosporin, but that's not super common. But just keep in mind kind of that stepwise approach you're going to get into. Okay, first thing always should come off is systemic corticosteroids. With Crohn's, it'll be a little bit different, mainly being there's no topical options for these patients here. You're going to see that you're still using your salicylate products here. Again, sometimes they may require antibiotics, but this is going to be plus or minus for many of them. For more severe cases, that's where again we can talk about using corticosteroids as a bridge to get them onto something like a monoclonal antibody or something like azathioprine or 6-MP. Okay, methotrexate might be more likely to be used for these patients here. With Crohn's, I think there's probably more evidence for its use as opposed to UC, so that's one little bit difference there in terms of therapy. And again, for the more severe cases, you're going to get them, try to get remission initiated with IV corticosteroids, and then if that still doesn't work, you can try utilizing something like cyclosporin. I'd probably try to hold off on the cyclosporin as much as you can because the side effect profile is not great. But something like monoclonal antibody tends to have pretty rapid onset of action and tends to work well for a lot of patients. So, and again, still try to taper off the corticosteroids if possible. As I mentioned, with maintenance of remission, that's our main goal of therapy there, but you can utilize sulfasalazine, 5-ASA, which is mesalamine, we know, azathioprine, 6-MP, infliximab, any of those are fine for chronic use for ulcerative colitis. The same thing for Crohn's, except you may utilize methotrexate and antibiotics more chronically, so that could be another option there. And as I mentioned, corticosteroids have no role in maintenance therapy, so try to wean them off of that as best you can, okay? All right. So any questions on that as I get in PowerPoint? You're going to see a lot of crossover in terms of the medications, which is handy because it's a good segue between talking about all these autoimmune conditions here. Again, feel free to participate in the chat. It makes it more fun for me and less boring for you, I hope. Or on the sticky board, anyway. Okay, so moving on, next we have our rheumatology topics here. Basically, RA is going to be this sort of chronic inflammatory disease that's more affecting the joints, whereas with something like UC or Crohn's affected the GI tract. Now we're talking about the joints specifically. And again, you typically see this in female patients more so than men, although men can still get it, certainly. And the biggest thing we're going to be seeing is that we're trying to stave off this sort of permanent damage done to the joints over the long term. This is not something like osteoarthritis where you can just switch out a joint, like a knee replacement or something, because the body's still going to be reacting negatively to the joint tissue, right? And it can be more of a systemic thing as opposed to just affecting like someone's knee if they were, an athlete or something growing up, something like that. I was about to say sports player, but that doesn't make sense. Athlete is the term for that. Basically, though, what we're seeing is that the joint lining, the capsule, is going to be chronically inflamed. And over time, you're going to see that, just with things like your white cells releasing these lysozymes and just chronically eroding that joint, you're going to find deformities that can happen here. You can find limited, mobility of the joints, things like that develops over time, and certainly quite a bit of pain that goes along with that. And again, the problem is that your body's not able to tell itself from foreign tissue and just attacks itself unnecessarily. So you can see what this would look like between someone with a normal joint versus someone with osteoarthritis, where it's more of a mechanical issue, where they've basically worn down that joint over the period of time, either due to obesity or overuse, whatever the case may be, due to occupational issues or whatever. Versus rheumatoid arthritis, it's not really the cartilage being worn down, it's just all this inflammation causing damage to the surrounding tissues that lead to a lot of the pain, the heat, the eventual joint destruction, deformity that can happen in these patients here. So for these patients, we're going to focus both on acute relief of pain and inflammation, and then we're also going to talk about trying to slow down disease progression, talk about medications that are used to try to save those joints as best we can over the long term. And so that's what we're going to call our disease-modifying anti-rheumatic drugs, or Demards, which we'll get into in just a little bit here. So Certainly, in terms of pharmacologic therapy, it's important to get things like physical and occupational therapy going. This is typically painful for patients, so they may not want to be compliant with this. If they can lose weight, if they're overweight, that can help out with joint stress as well. Surgery is not really going to be an option for these patients. This is more so for osteoarthritis, which I'm not going to get super in depth on today. We're going to talk more about that when we get into pain management coming up in the next PowerPoint. So kind of rest easy on that. But what we're going to be doing for these patients here for chronic treatment of RA, we're going to include our Nsaids and low-dose corticosteroids. As I mentioned with UC and Crohn's, the ideal thing would be to get them off of corticosteroids as quickly as you can. For a lot of RA patients, they may not be able to do that. They may just be on chronic low-dose corticosteroids for the long term, and so it's important to recognize some of the long-term side effects, which we'll get into in just a little bit. For acute exacerbations, that's where we're going to be utilizing our IV corticosteroids typically, and then we'll get into our Demards. I'll elaborate on that in just a few moments. And then for specific cases, for instance, like a knee effusion, you can do things like aspiration and corticosteroid injection. I remember I had one kid who had juvenile rheumatoid arthritis that was in the ER for knee pain, and the rheumatologist came down to do an intra-articular corticosteroid injection, but first he wanted to aspirate off the fluid, and I think they pulled off like 200 mLs of fluid off this kid's knee. I mean, he came in so red and swollen. He was in a ton of pain, and just having that initial fluid taken off made him feel so much better. There was just so much pressure built up there from all the inflammation, all that exudates was just building up in that joint. So that can be very effective for particular joints being affected here. So, as I mentioned with the Demards, these are disease-modifying anti-rheumatic drugs. These can either be of two categories we're going to mention here. There's the biologics and the non-biologics. Biologics are going to be like protein-based products, so very similar to what we talked about just a moment ago with infliximab and adalimumab. Those are biologic anti-rheumatic drugs, as we'll see here, so we can talk about those again. Also find some non-biologic options as well. These should be initiated as early as possible because they help to have more favorable outcomes. You're going to have less joint deformities, better function over the long term, so this is mandatory therapy. Okay, things like Nsaids and corticosteroids are going to be used for more immediate and symptomatic relief, but they don't necessarily have any benefit over the long term in terms of disease progression. So I'm going to talk about first our traditional Demards. These are also what we consider to be the non-biologic Demards. These include methotrexate, which I talked about briefly a minute ago, hydroxychloroquine, which you've been up with the news over the past maybe 6 to 8 months, you've probably heard of. We'll talk about its use here with rheumatology. Sulfasalazine, which we mentioned before, and then leflunamite. Again, you can see a lot of crossover here amongst the medications because, the pathophysiology is relatively the same. It's just a matter of where the disease is affecting the patient, whether it's the joint or whether it's the GI tract. And then with our biologic Demards, we're going to have ones that affect tumor necrosis factor. So I'll focus on a few of these, but some we've already run into include infliximab and adalimumab. Some of these can work as what we call co-stimulation modulators. I'll talk about that mechanism a little bit later. We have abatacept there. We have drugs that affect IL-6 like tocilizumab. We have CD20 antagonists like rituximab. And then actually a new class that has come out that's not traditionally a biologic, but I'll talk about this and being sort of differentiated from the biologics as something called tofacitinib or Xeljanz. This has a new novel mechanism. So there's been a few other ones that fit into this category as well as JAK inhibitors, but this is the first one, so I'm going to focus on this because it's probably the more common one you're going to run into. So generally speaking, we may not know the full mechanism for how these drugs work in terms of them, slowing down progression of rheumatoid arthritis. We will find overall that methotrexate and hydroxychloroquine probably have the best efficacy to toxicity ratios, and most patients will probably be started on methotrexate with RA. We'll find that if you get started on something like methotrexate and low-dose corticosteroids, they can probably stay on that for years before they really need to consider advancing therapy due to progression of their disease. Good. And in some cases, you may need to combine multiple Demards, and that's going to be an important thing there of considering which ones are good to combine and which ones you don't want to combine, right? So being able to identify and decide what would be an appropriate regimen. So you could have a test question that comes up saying a patient comes in on this, what would be a reasonable thing to add on to it? And we'll talk about what those options might be here a little bit. As I said, methotrexate is an old drug. It's been around for a long time, and so it has sort of the best long-term data with it, and generally will form sort of the backbone of a lot of regimens for patients. You may see patients on methotrexate plus something else pretty frequently. So with traditional DMARDs, they have a slow onset of action. So they take about 3 to 6 months. And this is why you'll have patients also on Nsaids and corticosteroids for this initial period in order to cover them sort of as bridge therapy until these DMARDs can kick in. So that's kind of the big thing there, is you're bridging them until these drugs can take effect, because they do take a while. Some will have a little bit faster onset. So for instance, like methotrexate and leflunamide, about 1 to 2 months. So it could be one reason to go with one of those as opposed to something else like hydroxychloroquine, for instance. With the biologics, they tend to kick in much faster. So within a couple of weeks, which is nice from a symptomatic relief standpoint there. Now, all of these therapies will result in immunosuppression. So specifically with the biologic DMARDs, you should be checking them for TB. I can guess that for most patients being evaluated for RA, they're probably going to get a TB test regardless. That's probably just good practice. And so I definitely recommend checking that out. And then you also want to consider getting vaccinations up to date before starting immunosuppressive therapy. Generally speaking, especially with the biologic DMARDs, you want to try to give any vaccines before you start therapy. There's a couple issues that pop up here with these. So as an example, when we talk about vaccines, there's two sort of big delineations. There's several varieties of vaccines, but the main ones you'll hear about are the live attenuated ones, which are weakened versions of a particular virus or bacteria. So for instance, if you hear about the live attenuated flu vaccine, that's the kind that you can get intranasally. That is a actual flu virus, but it's been just weakened. It's made it wimpier, so that way your body can have a reaction to it. You can develop immunity, but it should not cause disease. Okay. The other type would be like an inactivated or killed vaccine, which is basically you killed off the bacteria or virus, and your body still has a reaction to the components that are there. You may not just have as strong of a reaction because of the fact that it's not live and actually able to replicate like a attenuated one would. So the thing here with patients on immunosuppressive therapy is that one, if they're getting a killed or an activated type, they may not be able to mount as good of a response. So they may not be able to have as good of an immunity to it as you would see with someone who had a fully functional immune system. Okay, so that's one issue. Not a contraindication of getting, a killed vaccine or an inactive vaccine, but it's something you may consider. For patients they're on immunosuppressive therapy, getting a live vaccine, that's a no-no. You don't want to combine a live vaccine with immunosuppressive therapy because they may actually not be able to get rid of that weakened virus or bacteria, and it may start to replicate on its own and cause disease in the patient. Okay. So live attenuated vaccines are no-go in immunosuppressive therapy while that's going. And then killed or inactivated vaccines, those are okay to give. You may just not get as good of a response. So as an example, say it's time for your flu shot. It's coming up. It's winter time. You can have either a live attenuated kind or you can get the killed inactivated kind. If you get the IM shot, that is the killed kind. Also some recombinant kind as well, but I'm not going to do that. That's the killed kind, you get IM. If the intranasal, that's the live attenuated. So if someone was on methotrexate, for instance, I would give them the IM shot, knowing that may not get full response out of it, but it's better than nothing. I would not give them the intranasal, the live attenuated kind, because it could actually cause flu in those patients, right? Because here's people that say, oh, every time I get the flu shot, I get the flu. No, you're just having an immune response to that vaccine, but these patients could actually get the flu if they're on immunosuppressive therapy and they get a live attenuated virus. Okay, so kind of a long way to say, okay, which one vaccines to give, which ones not to give. I like to explain the whys of what we do because that I think it helps you to intuit why, instead of memorizing these facts here, it helps you to kind of intuit things, and that makes it easier to replicate like on a test or when you're in your clinicals. Also, if patients are taking DMARD therapy, it's also recommended they get certain vaccines earlier. So as an example, the American College of Rheumatology says, okay, let's give herpes zoster at age 50 instead of 60, right? So little things like that. So let's talk about methotrexate first. This one is going to be a folic acid antagonist. Okay, so basically your cells, especially the rapidly dividing ones like your immune cells, are utilizing folic acid in order to produce new nucleotides like purines, right? If you are unable to produce new nucleotides, you can't make DNA, you can't make RNA, and those cells are not going to replicate. Okay, so by blocking activity of folic acid, these immune cells cannot replicate unless you get immunosuppressed, right? Which is good for these patients, is what we want. As an example, you can see what basically it inhibits the enzyme tetrahydrofolate reductase, or I'm sorry, dihydrofolate reductase is what it inhibits. And it makes it impossible for the cells to recycle methotrexate in order to use it for these cells here. So tetrahydrofolate, you can see how methotrexate had, they look pretty similar to one another. It can make sense how the cell could get confused and use one versus the other to inhibit it, basically. Savannah was saying, are all these RA patients on Demards for life, or is it more to get the disease response down so the body can keep it down on its own? A lot of patients are going to be on this for life, as it turns out. Not something you typically hear about patients outgrowing necessarily, not to say that it couldn't happen, but frequently it's going to be for life in a lot of cases there. So yeah, and again, that's why we look for things that are, you know, tolerable from a side effect profile standpoint and also efficacy. So that's why so many people get put on methotrexate. They can be on that for years and years without really need to change things, because again, depending on how severe the disease is and how it's progressing, this may be sufficient therapy for a good long time, right? Anyway, so big side effects you're going to run into this are going to be things where rapidly dividing cells are being inhibited from replicating. So what are your rapidly dividing cells? Well, your white cells, your GI cells, your hair cells, right? So these are all things you'd expect to see. And again, consider this versus like oncology. You know, if I have a patient with leukemia, I'm trying to get rid of all their white cells, all those cancerous white cells. I'm going to give much bigger doses. For something like this, I'm just trying to tamp down the immune system a little bit, just kind of chill it out. This is something where the doses are much lower, right? So from that standpoint, the side effect profile would be more mild than if you saw someone getting this for cancer, as an example. So again, the dose does matter here. But you can see things like bone marrow suppression. So you can see things like platelet counts drop. You can see white counts drop. You can see things like oral epithelia being affected. So you can get stomatitis, where they actually get like ulcers in the mouth as a result of that. Again, I apologize for the screaming kid in the background. Things like the liver can take a hit here. So you definitely want to monitor LFTs. Pulmonary function can take a hit over the long term. And again, we're thinking years and years, maybe decades, that patients are taking these drugs for this stuff to develop. The other big thing too is you got to monitor for renal function. Okay, make sure that they can actually get rid of the drug, because otherwise levels will build up. They're more likely to experience all these other toxicities. This is the thing too you run into where, you know, say a patient gets diagnosed with rheumatoid arthritis in their 40s and they're taking methotrexate for the next 2 decades. If you never go in and recheck their renal function, which sometimes happens, they may be on way too big of a dose, right? So you got to make sure you're going back and readjusting those as necessary. Certainly, do not give this for pregnant patients, mainly because, you know, if you think about rapidly, yeah, it is too early. I agree too, but some people got to get to school, so they got to do what they got to do. But in terms of pregnancy, you know, if you think about rapidly dividing cells being affected, a fetus is just a big bunch of rapidly dividing cells, so it makes sense how that would be affected pretty substantially there. Renal insufficiency, if they have low creatinine clearance, they are not able to get rid of the drug, they'll just hold on to it, and that can cause a lot of toxicity there. Look out for liver disease, and again, check out the CBC, because again, this can worsen thrombocytopenia, leukopenia, etc. So, as I mentioned, methotrexate is probably the most common. It's probably the best tolerated out of the bunch, and has a fairly rapid onset of action, and again, has a pretty acceptable level of adverse effects. Not ideal, but it's acceptable. And you can see different routes that are being given here. Some patients will do like once weekly sub-Q injections. Some people just do daily PO. They have a lot of options that are available for them. But again, with monitoring, look at the CBC, LFTs, serum creatinine. And again, you can monitor monthly up front to see how they're doing, and then you can extend that out depending on how they do from there. And again, if they are childbearing potential, then consider doing a pregnancy status for them. You know, obviously, if they're in their 60s, less likely of a concern than if they got it in their 30s, for instance, right? And then some patients will also get folic acid along with this. Note that this is just more so to help out some of your other healthy cells, more so than those rapidly dividing ones, as I mentioned. I don't know necessarily that we've clinically shown that this really prevents a lot of side effects, But again, getting a little extra folic acid is probably not going to hurt. It's part of your normal multivitamin anyway, right? So another option here includes leflunamide. This is helping to inhibit pyrimidine synthesis, so kind of a similar mechanism, although it doesn't affect folic acid specifically, but it can directly inhibit pyrimidine synthesis. So that way you get less lymphocyte proliferation, so less white cells dividing. This is also a prodrug, so this is one that has to be metabolized into the active component there. This one is pretty similar efficacy in terms of methotrexate, so this may be used as an alternative, especially if someone has like renal disease and they could not get methotrexate. You could use this instead potentially. And the benefits, again, pretty fast onset, which is another benefit here. So in terms of adverse effects, you can see here hepatotoxicity is going to be a big one. So this is if you're looking at combinations of drugs, like I probably wouldn't want to do leflunamide plus methotrexate because that could just worsen the hepatotoxicity. And certainly if you're combining drugs, you can get more immunosuppression, more hematologic toxicity, so you're going to be monitoring for that anyway. Interestingly enough, this is another teratogenic drug, meaning it can cause harm to a developing fetus. This one's interesting in the fact that it undergoes what we call enterohepatic recirculation, which means that as it gets eliminated through the biliary tract, it gets reabsorbed from the GI tract, and so it extends its half-life pretty significantly. And so you can find that even though if a patient who wanted to become pregnant stopped taking this medication, they may have elevated levels of this drug for months potentially before it dropped down to a safe enough level to conceive a child. And so sometimes what we do is we actually give the bile acid sequestrant we talked about last semester, cholestyramine, and that will bind it up in the GI tract and help to eliminate it more quickly. That way levels can get down to be sufficiently low enough to that way they can basically become pregnant and not worry about the drug affecting that developing fetus there. Obviously, monitoring LFTs, CBC, pregnancy, those are big. Next, I have hydroxychloroquine or Plaquenil. This is actually a derivative of an anti-malarial drug, but this is probably the least toxic, but also the least potent DMARD. So if you had the most mild cases of disease, this may be an agent to go with. Or perhaps if you had someone who's on methotrexate to begin with, you could add this on. That can be either initial monotherapy for mild cases or adjuvant therapy, so add-on. And so you can see here that it basically has less side effects because it doesn't really affect the replication of white cells so much. It more so is inhibiting things like neutrophil locomotion. You're not getting white cells being able to travel to the site of inflammation as well. And also can't, utilize the complement system as well. So overall, wimpy in terms of anti-inflammatory action, but also much less of those side effects. I don't have to worry about CBC being affected because the white cells can still replicate like normal. I don't have to worry about, things like bleeding because platelets shouldn't be affected here. So that's kind of the benefit. Again, the downside being that doesn't work as well. Response is a little bit slower too. It's about 2 to 4 months. And as I mentioned, no renal issues, no hepatic issues, no myelosuppression, so less monitoring is needed. So if you can catch it early, this may be a decent option for those patients for a period of time. Some things you can find, mostly it's going to be GI effects, but you can see some retinopathies here. So you do want to document visual acuity, both at baseline and at follow-up, see if there's any issues coming up from that standpoint. And then there are some dermatologic reactions. So you can see some increased skin pigmentations. For instance, here you can see some graying of the skin. So those are things you can see with hydroxychloroquine, sort of unique to it versus anything. We talked about sulfasalazine before. Again, if you remember, this gets cleaved into sulfapyridine to 5-ASA. These do get absorbed and can have systemic actions. I've not personally seen a lot of patients with RA on sulfasalazine, but it can be an option here. It's also thought to inhibit TNF, kind of similar to some of those monoclonal antibodies we looked at before, and can help out with oxidative stress by being a free radical scavenger, right? Free radicals are reactive oxygen species that can go and just wreak havoc within the joint, affecting proteins and cells and whatnot. So by scavenging those, getting rid of those, it can help to decrease overall damage done in the long term. This one here is another one you can see pretty fast response with usually within 1 to 4 months or so. A lot of patients stop using this because of side effects, so things like developing alopecia, elevated LFTs, and so typically if you're going to use this drug, start with low dose and gently titrate up. Again, most of these patients are going to be taking Nsaids and corticosteroids to deal with the acute or the acute problems of RA in the first place, like pain and inflammation, you have time to work these up in terms of their doses. So you can titrate slowly up and see what they're going to tolerate, and then you can treat some of the side effects supportively. So, if they're having nausea, vomiting, try taking it with food, see how that works. But alopecia, not a lot we can do for that besides take the drug away. So you're going to find leukopenia and thrombocytopenia are less likely to occur than something like methotrexate. So that could be one thing. If patient developed thrombocytopenia on methotrexate, this could be a good alternative as an example there. You will find a lot of drug interactions within the GI tract itself. So it can bind up with things like antibiotics. It can bind up iron supplements. So from that standpoint, you would want to separate these out. Usually, something take like your antibiotics like an hour before the sulfasalazine or like 3 to 4 hours after, and that will help to prevent that. And then also of note here, can turn your urine and stools yellow to orange. Again, it's always a good idea to tell patients whenever you're going to be altering the color of the urine or stools, because that could be a pretty worrying symptom if they're not prepared for that. So those are the traditional DMARDs. Now we have this newer class here. I kind of use this to bridge the gap between the traditional and the biologic, because this is a new class, but it's still orally bioavailable. All the biologics are going to be injectable products here. This one's the newest class. It is as effective as a biologic, but it's also going to be orally bioavailable. So good from a compliance standpoint here. But basically, this drug is called tofacitinib or Xeljanz. And you have these receptors called tyrosine kinase receptors, and they have all kinds of varieties of them in the body, some for insulin, some for growth factors. In this case here, you have a lot that are responding to things like interferon and interleukin-2 as an example. And when these get activated, they cause all kinds of different cell signals to occur that generally will change things like gene transcription, stimulate cell growth, cell replication. So by inhibiting this process, in this case here, these JAK proteins are being inhibited, you can decrease the overall reproduction and, production of new inflammatory cytokines and all of that. So very specific in terms of its target, and also pretty good at decreasing inflammatory gene transcription. Overall inflammation is reduced. So I'll talk about how we're going to combine these drugs here, but in terms of overall efficacy, this is probably on par with a lot of the biologics that we're going to look at here in just a second. But as I mentioned, it's bioavailable orally, which is a good alternative. Then one has to inject themselves. They can just take a pill for this, and it works very well. So this is more for moderate severe cases, especially in patients who have failed methotrexate. As I mentioned, you can use it as monotherapy. It could be used by itself or maybe in combination with other DMARDs there. You do not want to use this with other biologics. You'll tend to find that in general, you don't want to combine multiple biologics or tofacitinib plus a biologic, because immunosuppression is too great. The risk for secondary infections is going to be too high. Okay, but like methotrexate plus Xeljanz is totally fine, right? We'll look at a couple of slides that illustrate that here in just a little bit. This is another one where you definitely want to check for TB before starting it. And then you can adjust the dose based on things like renal dysfunction, hepatic dysfunction, or because this drug is metabolized by CYP3A4, if you have a CYP3A4 inhibitor on board, so something like a macrolide antibiotic, for instance, you would want to adjust the dose, because otherwise you may get too high of a level and that can cause too great of an immunosuppression. Serious infections is probably the biggest risk seen with this one. So again, making sure they're washing their hands and staying away from sick contacts and masking up and all that good stuff. And then there are some small risks for other malignancies, but again, I don't know if we had the full story on that just. Okay, so then moving into the actual biologic agents here. Again, these are typically either used for failure of more traditional DMARDs, or if they can't tolerate the traditional DMARDs, you can utilize these. I'll put a few price tags on here just to give an example of how expensive some of these agents can be here, because some of it can rival the price of pretty expensive cars here, as we'll see in terms of a yearly basis. The nice thing with these is there's very little monitoring, because they're not really going to do anything to directly affect cell replication. They don't really affect the liver. They don't affect the kidneys. So very little monitoring, which is nice from that standpoint. However, you will have an increased risk of infection as compared to something like methotrexate. You also have that risk for TB, so definitely check and make sure they are tested for latent TB beforehand. And as I mentioned, if patients get sick while taking this, you probably want to go ahead and discontinue it so they can fight off that infection. and then don't give live vaccines along with it. Either do it beforehand or after, or if you can, utilize like an attenuated, not attenuated form, a killed form or recombinant form. That's that example of flu vaccines I mentioned. You don't want to use intranasal. It's a live attenuated form. You want to use the intramuscular, which is a killed form. So the first class we'll talk about are going to be our TNF-alpha inhibitors. And again, most of these are similar in terms of their side effects here. I mentioned this in the last section, but like CHF is going to be one thing we're worried about. So if they have a history of CHF, I'd probably avoid utilizing some of our TNF-alpha inhibitors, which I'll go into the specifics in a moment here. And then there could be a case where you could actually induce or exacerbate multiple sclerosis, as I mentioned in the last section, risk for demyelination to occur there. Again, if any kind of like neuropathic symptoms develop while taking this, I'd probably just discontinue it and for fear of worsening that. But it's a pretty low risk. And then some risk for lymphoproliferative cancers. The first one to have here is etanercept. This is actually going to be binding to TNF-alpha specifically. It actually is interesting because it looks like 2 TNF-alpha receptors, and it will sit there and bind it up to it. Notice here how it's attached to the Fc portion of a immune globulin. So it's going to bind to the TNF-alpha, and then once it does that, it inactivates the complement system and gets rid of it. So it inactivates the TNF-alpha, so it can't cause further inflammation to occur. You will probably use something like etanercept either by itself or in combo with methotrexate or another traditional Demard. But generally speaking, because of the price and mainly the price and the fact that it's an injectable product, you're probably going to be using these as second line. You can get away with oral methotrexate, much cheaper, even though the side effect profile is not ideal. You'll probably just try to use that first, right? As an example, you're doing this one sub-Q twice a week. So some patients may not want to inject themselves. Some patients have needle phobias, etc. And again, about $15,000 a year. And not the most expensive drug out there, but definitely an increased cost as compared to something like methotrexate, which is usually pennies for a tablet. Infliximab is probably used much more commonly than etanercept. This one is basically, again, the same mechanism, just designed to go against antibody designed against TNF-alpha. This one I see used pretty frequently in our infusion center because we do get juvenile rheumatoid arthritis we treat on a routine basis here. And again, either add on to methotrexate or as like a second line as an alternative to methotrexate in a lot of cases there. But you could use it with leflunamide. You could use it for lots of different things. Interestingly enough, because these are antibodies you're injecting to the patient, your body can also develop reactions to that, right? So that can be as mild as it over time develops antibodies that neutralizes the infliximab, which is not great because then the drug is not effective anymore because your body's mounting a response to it because it's foreign protein. Or in some cases, you may find that you can have anaphylactic reactions. Okay, so at the very least, you can get what we call infusion-related reactions as a result of this foreign protein. So patients will come into the infusion center, they'll have this infusion done, they'll start to develop chills, myalgias, maybe a low-grade fever. So it's important to consider pre-treating for administration of something like infliximab. Why would you need to do that? Well, because it has to do with the type of protein that's being injected, right? So the more human the protein looks, the less likely your body is to react to it because it looks like normal protein to it. In some cases, you're going to find these products will contain more murine protein, murine meaning mouse. And again, it's not like we're getting like, harvesting mice meat or something like that to produce these proteins here. It's just the amino acid sequence looks more like a mouse protein and your body may react to that. So with something like infliximab, this is actually what we call a chimeric protein. You can tell it says an X in the name. It's like you're crossing human and mouse protein, and that leads to a higher risk for having a reaction to it. So that's why we kind of note that. Also, your patients may want to ingest some cheese as a side effect, but just indulge them. That's totally fine. Cheese and crackers are good. I'm just kidding. But, so that does have that clinical implication of having a higher risk for having reactions when infusing the drug. So something like infliximab, they will come into the infusion center to have infused. We're going to pre-treat them with things like corticosteroids. We're going to give them things like Tylenol in order to deal with those infusion reactions. And then we'll also have available, in case they have a really true severe allergy, we can treat them with things like epinephrine and whatnot in order to get that, prevent the anaphylactic reaction from kind of progressing. So That's the one downside. Is they have to actually come in order to get the drug given to them. But you'll notice here that sometimes you can give every 8 weeks. So at that point, there it's nice from a compliance because they're only getting it 6 times a year once they get sort of settled on it. Yeah, please don't give it with cheese. That was just a joke, and I don't want anyone to exacerbate someone's lactose intolerance on account of my bad jokes there. But very good. I'm glad I could fool a few of you. I'm just kidding. But again, like in this one, you have to give like over 2 hours, right? Because of the reactions you can have there. So as I mentioned, how would you manage that? Acetaminophen is good for the fever and the myalgias. You can give corticosteroids beforehand to prevent the reaction. And again, most of the time they're going to benefit from those corticosteroids anyway, as we'll see here in just a little bit. So there's that. And again, epi you'd say for if they're having like a true anaphylactic reaction, right? Sonya's saying, just tell your patient it'll be like Spider-Man, where you get the drug and become Tom the Mouse and from Tom and Jerry. Yeah, that would be nice if you dealt superpowers from these drugs, but unfortunately, you just get like tuberculosis from it. So not a great superpower overall, I would say. Now to compare that to something like adalimumab, if you look here, there's a U in the name, so it seems like for human. I don't know how they come up with this stuff, but that's how I remember it. This one is less likely to cause a reaction because there's no mouse protein, it's all humanized protein. And so, for example, with this one, patients can give this at home. They can give this sub-Q at home because they're less likely to have a reaction to it. So you're saying, well, why would you use infliximab versus adalimumab? A lot of it just has to do with how the patient's going to respond to it. Some respond better to one versus the other. Sometimes it's an insurance thing. It really just depends on the provider, the patient, and what they're able to get access to. But same mechanism for this one, just a matter of how you're going to be giving it. In this case here, the patient can give it at home to themselves, but same reactions, increased risk for infection. They can get injection site reactions, so make sure they have good technique in terms of cleaning off the site they're injecting into it. Make sure they're rotating around, not injecting to the same spot every single time, because that can lead to scar tissue formation, lipodystrophy, and things like that, which we don't want to have occur. So those are like your main TNF alpha inhibitors. There are others that are out there. I'm just focusing on the common ones you're going to run into. Next, we have abatacept or Orencia. This is for more, again, patients who have failed disease. Most of the time, if you're going to go with a biologic, a TNF alpha inhibitor is the way to go, 9 times out of 10. Once you have failed that, that's when you start to get into some of the other biologics. So in this case here, someone has failed infliximab, you can go to something like abatacept or Orencia. This is basically working to inhibit this co-stimulation modulator, so trying to inhibit this complement system and dealing with the CD receptors, not the complement system, but this basically the CD receptors on these different T cells. By preventing those two from interacting together, it prevents the T cells from being activated in the first place. So overall, you get less inflammation as well, right? As you can see here, some patients will respond well to this if they failed TNF alpha therapy. So that's going to be one benefit. Oh, something I forgot to mention back on the slide when I was mentioning the reactions you can have to the drug. Note here that by giving someone methotrexate or another immunosuppressive drug, you can actually prevent that reaction of your body to that protein. So actually, for some patients, if they get methotrexate plus infliximab, it keeps the infliximab working better for longer to prevent your body from developing antibodies to neutralize it. So that could be one benefit of utilizing the combination here. So just one thing to note with that. Anyway, so back to abatacept. Again, generally as an alternative to patients who have failed other TNF alpha blockers, and in terms of reactions, pretty minimal, usually just injection site reactions there as well. So nothing to really write home about. Next, we have rituximab or Rituxan. This is actually another chimeric protein. So this would be another one that patients would need to come in to get an infusion for the drug. This is another one I see a ton of infusion reactions to. So we really heavily pre-treat this one with like corticosteroids and Tylenol and all of that. So again, has to be pre-treated. This is another one that it will be used as an alternative to a TNF alpha blocker if they've failed that. But this one in particular works against CD20. And so it's a protein you typically find on B lymphocytes. And so by binding to that and inactivating it, you basically get this big depletion of your B cells. And also you're presenting less to the T cells, and so they get less activated as well. And this is actually something you can see used for certain types of leukemia. And so, I won't get into that too much, but certain types of pediatric oncology, you may see this being used for that purpose as well. More commonly, though, I see it used for things like rheumatoid arthritis and like really resistant treatment for like Crohn's and things like that. And then we have another mechanism here of tocilizumab or Actemra. This one is a pretty popular one I'm seeing with a lot of my pediatric rheumatologists for patients that failed infliximab. I see a lot of people switching over to utilizing this, having some benefit. Again, from a side effect profile, this one, biggest thing to note here is things like liver function tests you want to check for, and look out for GI issues that are popping up because that could be indicative of this perforation. I've never seen a case of this happen, but it would be something I would not want to have. I would want to keep it on my radar, so at least I'm aware of it. I can ask the question, see if they're having issues there. Interestingly, even though monoclonal antibodies don't really have a lot of CYP interactions, this one actually induces CYP3A4. So it can affect things like warfarin, birth control, statins. So you would want to be careful because it would drop levels of those drugs and could potentially cause issues. So for as an example, if I had like say, a patient of childbearing potential, say they're younger, they have juvenile rheumatoid arthritis, so they're in their teens, and they're on birth control because they're on methotrexate because they don't want to get pregnant, and they're also on Actemra. You can see the interaction here where the Actemra could drop levels of the birth control and potentially cause that patient to ovulate and get pregnant potentially, right? So little things like that you want to consider when looking at the drug interactions between these agents. So you'll see either with patients with biologics, they can either have what we call a primary lack of efficacy, where you really don't see any response from the drugs in 3 to 6 months. It just doesn't work for them. Sometimes what you'll find is they have a secondary lack of efficacy where it works at first, but then it kind of goes away. And a lot of that has to do with your body developing antibodies to that. So you see that more so with like rituximab and infliximab. And then other reasons people fail is because they don't like the adverse effects. And so either secondary infections or something like that. As I mentioned, you can either use these by themselves or as like an add-on to the non-biologics, like methotrexate commonly being the most likely one to be used as a backbone to the biologic regimens here. And again, if you fail one, you can switch mechanisms. So if you fail one TNF-alpha blocker, try utilizing an IL-6 inhibitor or CD20 inhibitor, things like that. In general, though, you don't want to combine different biologics because the immunosuppression is too much and their risk for secondary infections is high. Now, corticosteroids are going to be very commonplace. You'll find a lot of patients with RA need to be on these chronically because they are anti-inflammatory, they are immunosuppressive, and they help out all different processes in the inflammation cascade, less prostaglandins, less cell migration, all that good stuff, right? As I mentioned, you'll see these used oftentimes like daily. They may be on daily low-dose corticosteroids, maybe just a little bit of prednisone every single day. They can be on chronically for that. They can do what we call bridge therapy, where if you're initiating them on a new DMARD, this can kind of bridge that gap and waiting for those DMARDs to kick in. So like methotrexate may take a month or two to really start working. You can use corticosteroids as an anti-inflammatory to bridge that gap until that drug kicks in, right? Or you can do it for more of a disease flare-up where they're having an acute exacerbation. That's where you can utilize these drugs in order to really knock down the inflammation strongly until they can kind of get back into remission there, okay? We'll call those either like short-acting burst therapy, or sometimes what we'll do is actually long-acting depot forms. When I say depot, it just means like a storage spot for the drug. This is typically done intramuscularly. So if you ever hear about like Depomedrol, that's a drug you can use basically inject into the muscle, and it slowly releases the drug over time, and that allows for both a natural taper to the level, because it'll naturally just kind of taper down on its own, so you don't have to worry about the adrenal insufficiency, and it's good for patients with compliance issues where they may be lost to follow-up, for example. You could do intra-articular steroid injections, which is good if you have just like a small number of joints being affected, but you can't do it too often. No more than 2 to 3 times a year, because you can actually see tendon atrophy, you can see joint destruction, increased joint destruction, which sounds counterintuitive, but that can happen. So that is one thing. Triamcinolone is a pretty common intra-articular corticosteroid, but those are the different ways they can be used. The lowest dose possible should be used. If you can get them off of it, that'd be great. Oftentimes you cannot, and so it's very frequent you'll find a patient just on prednisone plus methotrexate orally, and that's their regimen for many, many years there. But be aware of the side effects. Remember, this is having, RA typically kicks in a little bit later in life. So like, not to say that 40 is old by any means, but, a little bit later than some other diseases. So think about some of these things here, like osteoporosis. Is your patient going to be going into menopause soon and they're more worried about things like osteoporosis? Guys got to worry about it too, as the case may be. Things like, hyperglycemia. Do they have diabetes? Do they have hyperlipidemia? They're going to have risk for infections. All these things are really important to educate on and to monitor for, especially if they're going to be on it every single day, right? Now, NSAIDs are also really important here as well. These are going to be good for symptomatic management. They don't necessarily do anything for disease progression, though, right? So you may have a patient who's on like methotrexate and corticosteroids, and they may just be on NSAIDs as needed for pain, or they may be on it around the clock, depending on how severe the cases are. And again, they all work the same, mainly by inactivating cyclooxygenase, decreasing prostaglandin synthesis, which we know to be anti-inflammatory. I'm going to get into this a lot more in detail in the next section when we get into pain management, so don't worry too much about that. But the main thing you're going to see here is that most patients will probably be on daily NSAIDs, but again, they don't do anything for disease progression itself. You may need to switch around different NSAIDs to find the one that works best for your patient, because not everyone responds well to Advil, for instance. But just be aware of that. If you recall, one of the big things we talked about was the risk for GI complications from NSAIDs. I'll talk more about that next time. But the risk for peptic ulcers to develop with use of NSAIDs because they decrease the production of that protective barrier because there's less prostaglandins. There are certain drugs you can use which we call COX-2 selective, which mitigate that. Because if you recall, there's two main types of cyclooxygenases, COX-1 and COX-2. COX-1 is what we call the constitutive enzyme, and that's the one that forms that protective barrier in the stomach that's always being expressed. COX-2 is inducible, meaning if you have inflammation, that's when it gets ramped up. So for RA, COX-2 is the main one you want to focus on. Problem being is if you just inhibit COX-2, you actually end up causing people to have heart attacks and strokes. Not great. So you have to kind of balance that out. And so generally speaking, I'd probably use non-selective drugs for most patients. And then if they have a history of high-risk GI history, I'd utilize a COX-2 selective agent. Don't worry too much about that. I'm going to talk about that next time. Just know that patients with high risk GI history, so they either had a history of NSAID-induced ulcers or a history of ulcers, I would probably try to use a COX-2 selective agent. Just some examples to give you right now are celecoxib or Celebrex or meloxicam or Mobic, but I will talk about those next week. So don't get too worried about that. So as I mentioned, you can use combination therapy. You can use multiple non-biologics together. That's fine. I'd probably avoid utilizing methotrexate plus leflunamide because the risk for hepatotoxicity is a little too great there. So I wouldn't use those two together. In terms of traditional plus biologic, that's totally fine as well. You could use any biologic plus a traditional, and that's perfectly reasonable. It's fine. However, I would not want to use two biologics together, and I would not use a biologic plus tofacitinib or the Xeljanz. Okay, too much immunosuppression at that point. I could use Xeljanz plus a traditional. That's also fine as well. Okay, so I didn't talk about anakinra here. It's kind of a less used one, so don't worry about that one too much. Otherwise, that's the general rule of thumb there for rheumatoid arthritis. So any questions on that before I jump into the next section? So I'm about another 20 minutes here. So let's talk about osteoporosis and osteomalacia, kind of two things along the same spectrum here. Basically, we know this to be an issue of low bone mineral density. And why do we care about that? Well, we care because people can get fractures, right? If you trip and fall with brittle bones, you're more likely to get a hip fracture, vertebral fracture, femur fracture, and that could be absolutely devastating to these older patients. They may never recover from some of the disability they'll get from these fractures here. And the issue is really between the laying down of new bone, accomplished by our osteoblasts, and the taking up of bone by our osteoclasts, right? So osteoblasts lay down bone, osteoclasts take up bone. And so what we're going to see here is that this can be affected by a number of things. So a lot of hormones can affect this. So for instance, estrogen and testosterone tend to favor osteoblast activity. They're going to be anabolic in nature and lay down new bone. You're going to see PTH, your parathyroid hormone, is going to be the opposite. It's going to favor osteoclast activity, right? Because when do you express PTH? Well, when calcium levels are low, and you have to get calcium from somewhere. If you don't get it from the kidneys, you don't get it from the GI tract, and you got to get it from the bone, right? And so you're going to find that there is frequently an imbalance here where patients will have too much PTH, or they may have too little estrogen or testosterone, and that can lead to this imbalance here, right? Could also have to do with intake of calcium and vitamin D, but we'll talk about that as well. So what we're going to see is that calcium homeostasis is mainly affected by vitamin D and PTH. Both of these will cause increased absorption from the GI tract. You'll get more calcium being absorbed. It also helps with the absorption of, or reabsorption of, calcium from the kidneys, right? Calcium is normally eliminated from the kidneys. If you can decrease that and absorb more of it once it's been filtered through the glomerulus, then you can hold on to calcium better, okay? So we want to have this balance here. Also note here that, the vitamin D you may be thinking of is probably not the activated form. If you think about like from your diet or from the sun or from your food, or like from like, multivitamins and things like that, that's not the activated form of vitamin D. It actually has to undergo a two-step process where it becomes activated first in the liver and then in the kidneys. That's to go through both of those to become the activated 1,25 dihydroxy vitamin D, otherwise known as calcitriol. That's really important to know, because if you have patients with poor kidney function or poor liver function, you can give them all the vitamin D you want in the world. They may not be able to activate it and have any effect from that. So sometimes we have to kind of cut out the middleman, so to speak, and just give calcitriol directly. Okay. I'll probably talk about that more in the renal section coming up later on. But that's just something to keep in the back of your mind there. But again, you want to have this balance here. If you don't have enough calcium in the blood, then PTH is going to respond to that and say, hey, let's go ahead and get more of this. Let's try to get some out of the bone as best as it can. So our goal here is either to try to prevent low bone mineral density from occurring in the first place, or once it's actually already occurred, try to prevent fractures from happening, increase the strength of the bone, and if they've had a fracture, try to decrease, a lot of their pain experience with that. Try to make sure that they are going to, have, their activities of daily living not being affected too much, improve their quality of life. But again, once they've had one fracture, they tend to be more likely for future fractures as well, which is not great. You can see a huge increase in morbidity and mortality after one of these fractures. So anyway, it's important for the non-pharmacologic therapy to get into play here. So this is why you want to make sure they're getting good calcium intake. This can be a challenge because they may have issues with constipation, which we know calcium is going to worsen that. They could have lots of drugs that will bind to calcium in the GI tract. So if they're trying to take this with their thyroid supplement or their iron supplement, all that can bind to one another and prevent it from being absorbed. So that's not great as well. Make sure they're separating these out, right? Vitamin D, oftentimes they're going to require exogenous supplementation, especially if they're not getting out very much into the sun, or if they don't get it in from their diet, or if they are not able to convert it on their own, they may require something like calcitriol. So this is something you'll see a lot in patients that have chronic kidney disease. They're not able to convert it, but if they have a good kidneys and good liver, they should be able to convert that vitamin D no matter what. But a lot of people just don't have enough intake, so that's why supplementation is often important. Now, looking at actual medications are going to be needing to either treat or prevent osteoporosis. We're typically going to be seeing this is required for postmenopausal women and men greater than 50, either if they have established osteoporosis, if they have low bone mineral density, but they have like a 10-year probability of hip fracture of like 3% or more. So a lot of this is off probabilities, or like a 10-year probability of major osteoporosis fracture of 20% or more. So again, I'm not going to get specific on the indications here. I'm going to more focus on the drug therapy, but bigger the risk, the more important it is to get anti-resorptive therapy on board. And so that does include our calcium and vitamin D, which I already mentioned, but it also includes some of our new drugs here. So bisphosphonates, some of our estrogen agonists/antagonists, we'll call SERMs, which we'll get into in a little bit, calcitonin, denosumab, estrogen, and testosterone. So sort of the gold standard here are going to be our bisphosphonates. This includes alendronate, ibandronate, razendronate, and then zoledronic acid. These first three are orally available. This last one is IV only. That'll become important in a moment. Basically, what they're doing is they mimic something called pyrophosphate, which is a natural bone resorption inhibitor that we produce ourselves. So it helps to supplement that, and it reduces the number of osteoclasts that are maturing, the number of them, their lifespan, and so overall you get less osteoclast activity. So you therefore have more, relatively speaking, osteoblast activity. So you should have more laying down of bone than you do have resorpting of it. These drugs have terrible bioavailability, less than 1%, even if you take it exactly as you should. So because of that, administration is really important. I'm going to talk about that extensively here. But basically, if they're taking these drugs with any sort of other food or drink, it's going to inhibit its absorption. That's not great because it's not going to work very well. It actually has a really long half-life because it gets put into the bone, and stuff that gets stuck on the bone is there for a really long time. So it's like a half-life, like 10 years or something. But basically, if they cannot take it correctly orally, then that's where we're going to have to utilize our IV option. We'll talk about the issues of that in here in a moment. But most of the time, what you're going to see in terms of adverse effects, especially with the oral options here, are going to be GI complaints. These tablets have a tendency to stick in the esophagus as well, especially if patients are lying recumbent. That can lead to a lot of dyspepsia and heartburn. You can even see ulcers form here occasionally. And the unique side effect of the bisphosphonates is osteonecrosis of the jaw. There's a particularly unique side effect to this. And so you would want to monitor for that over time, make sure that the jaw is okay, because there's been some cases of like surgery needing to be done to repair that. Pretty rare, but it can occur. Anyways, how should they take these oral options? Basically, they should wake up first thing in the morning, having drank or eaten anything else, and then take their tablet with about 6 ounces of water. No other liquids, no coffee, tea, milk, no nothing. And then wait about 30 minutes before consuming anything else, and have them stay upright for 30 minutes. They may say, okay, I'm just going to take this and go back to bed for 30 minutes because I can't have my breakfast yet. Don't do that. Gotta stay upright. Otherwise, it has a tendency to stick in the esophagus, stick in your craw, if you will, and it will just sit there and erode that tissue. Not great. If they cannot do this, they cannot be compliant with this, or if the side effects are so severe, they can utilize yearly zoledronic acid infusions. And so the other ones I mentioned before may be given like weekly, monthly, but if they cannot tolerate any of those oral options, IV zoledronic acid once a year. Again, it is something from a compliance standpoint fairly easy as long as they schedule that yearly appointment, and then they don't have to think about it for another 365 days, which could be good for some people. If they cannot utilize those agents, maybe someone had an issue of osteonecrosis of the jaw, you could utilize something else like denosumab, which is another monoclonal antibody here. This actually binds to a protein called RANKL. RANKL binds to the RANK receptor, and RANK receptor is expressed on the surface of osteoclast precursor cells. Normally, this RANKL protein will come and stimulate osteoclasts to develop and to mature. By preventing that, by binding up this RANKL protein and neutralizing it, you get less osteoclasts developing. Okay, so overall less bone resorptive capability because you have less osteoclasts working. This is another one. It has to be given as an injection because it's a monoclonal antibody, as we note here, and is dosed every 6 months or so. From a side effect profile, was fairly decently tolerated, mainly some local dermatologic reactions, maybe some risk for skin infections. And there's some risk, they talk about bone turnover suppression. This may affect the overall strength of the bone in the long term, because if you think about it, you're constantly stressing your bones, you're constantly pulling calcium out, putting it back in, microfracture, all that stuff creates strong bones. By suppressing that, though, that normal turnover, maybe you can have some issues of strength and rigidity of the bone. Clinically, I don't know how important that is because, again, if they can't get treatment for this, they're definitely going to be a risk for fractures anyway. So, again, clinically, I'm not sure how important that is. So, usually if people cannot get bisphosphonates, they'll usually go to denosumab as a secondary. Another thing we can use occasionally, which we won't talk about too much here, is something called calcitonin. This is something that is more often used for hypercalcemias. I'll probably talk about this more in the endocrine section. Actually, we probably talked about already a little bit on that, so I should take this out. That's an old note based on class used to be run. But this is more so for hypercalcemia, more so than anything else, because it does have evidence for reducing vertebral fractures, but not hip fractures for whatever reason. We're not really sure. But basically, this drug is the antagonist to PTH. So whereas PTH causes more bone resorption by stimulating osteoclasts, this is going to inhibit that. So you can see why it might have some benefit for osteoporosis, but again, clinically we see that it's not as effective as your bisphosphonates are going to be. Interestingly enough, we've produced this from salmon sperm. I don't know why that is, but I always find it interesting when we have plant or animal sources for medications, and whoever the scientist that was that figured that out, I guess good on him. I'm not sure why he was investigating that particularly, but okay. And interestingly enough, this has to be administered intranasally. So as opposed to like an oral or an IV product, this is actually an intranasal product you can use to get the calcium under control. Another drug here is teriparatide or Forteo. This is typically used for patients who, again, cannot receive bisphosphonate therapy or at high risk for fractures. Interestingly enough, this one actually represents the first chunk, the amino acid portion of PTH. It actually has very similar activity to PTH. And you're just saying, well, wait a second, you just have too much PTH is the whole reason these patients get osteoporotic in the first place, or one of the reasons. And that is true. but interestingly enough is if I keep saying that, but it's probably not that interesting to you, but regardless, if you're chronically exposed to PTH, yes, you do get that effect where you're getting bone resorption occurring, osteoclastic or more overpowering the osteoblast. Yes, that is true. We have found that by giving intermittent pulses of this teriparatide, you end up getting more of an anabolic action out of the parathyroid effects of it. So parathyroid hormone can have some anabolic effects on the bone if given in short bursts. And so by giving this intermittently, you get those benefits without getting the resorptive aspects of it. So that's why we don't give it as a continuous infusion, but you just give it intermittently. And so for whatever reason, that helps out from that standpoint. There is a risk for bone cancer, so we actually recommend not giving it for more than 2 years because that risk for cancer does go up. So that would be something I'm concerned about. So those are most of the therapies. Typically for osteoporosis, you're going to start out with calcium and vitamin D at a baseline, especially if they're at risk for osteoporosis. Start with that, and then utilize the bisphosphonates as your go-to. If that is not going to be effective, then denosumab, maybe teriparatide, and very rarely calcitonin. It's probably the order that I would go in terms of that. Calcium and vitamin D would be there the whole time. And remember, it doesn't matter how good your drugs are if you don't have calcium and vitamin D. If you don't have calcium, they'll actually lay down that bone. It's not going to be very effective. Okay. All right. The last thing here we are going to talk about is gout, which I may cover here briefly. Basically, gout is an issue of they call it the rich person's disease because back in the day, only rich people got gout, and it had to do with the fact that they could afford things like meats, like red meat and things like that to eat. And so basically, that'll be important when we talk about the formation of uric acid. But this is the issue of hyperuricemia. You have too much uric acid that is precipitating out either in the joints, which is the typical gouty manifestation we think of, or it could be actually in the kidneys, for instance, or other interstitial tissues. So as I mentioned, the breakdown of purines is what produces uric acid. So either from our own cells breaking down with its DNA being turned into uric acid, or from things we're ingesting, like our meats, which is why I mentioned it was a rich person disease, because the people that were less well off could not afford to eat a lot of meat, so they did not get gout. Usually you're going to find that this will happen, gout will happen either as an issue of overproduction. So either you're having increased breakdown of nucleic acids, maybe you have excessive cell turnover due to certain types of cancer, or if you have underexcretion, either due to like dehydration or kidney functions impaired, something along those lines. But we'll talk about ways we can try to prevent gouty attacks and the ways we can treat acute gouty attacks. And so that's going to be broken down into our anti-inflammatories for acute treatment, and then urate lowering therapy for prevention of disease. So for acute gouty arthritis, typically non-pharmacologic therapy is going to be pretty limited in utility here, but we can get into using our Nsaids, corticosteroids, and a new drug called colchicine. Typically you want to start pretty early on. Some of your drugs will be more effective when started early. We're going to see here that combo therapy can be used sometimes. That's more so if you have maybe like multiple joints being affected, or if it's like really severe pain not managed with just one of these. We'll talk about Nsaids next week, so don't worry too much about that. But you already know something about Nsaids already as anti-inflammatory, so you can probably intuit how some of this will be utilized. Corticosteroids can be used occasionally, either as like an intra-articular injection. So you may do like intra-articular triamcinolone potentially. But more often, if you have a lot of joints being affected, like more than 2, you can utilize systemic therapy. So usually I probably do like 5 days of prednisone, see if that's resolved. Usually you don't need more than a week for a lot of these patients here. Like prednisone, dexamethasone, any of those are fine. But the new one we have here is colchicine, or Colchris. This is actually an antimitotic drug. This actually comes from a plant source. If you ever look up the autumn crocus, for instance, that's actually the source for colchicine. But basically, it prevents replication of rapidly dividing cells. So it does have a little bit of immunosuppressive effect. But for gout specifically, it inhibits microtubule formation. The microtubules are necessary for things like mitosis, which is why it can have an effect on replicating our cells rapidly dividing. But it also prevents like the locomotion of these cells. So neutrophils can't get to the site of inflammation as well because their microtubules are being affected. And so you can see here that this has been used for a really long time. It's an old drug, but unfortunately causes a lot of GI effects. And in fact, it used to be dosed. Basically, they would say, well, keep taking these doses every so often until you throw up. And then once you throw up, that was your max dose. You just found that out. Not great from that standpoint. So I think nowadays I see a lot more corticosteroids and Nsaids being used in a lot of cases. Also, you can run the risk, especially if they're taking this more long-term, for things like neutropenia, some neuropathy. So not great from a side effect profile. I still see some people that swear by it, but I probably wouldn't want to take it if I was having an acute gouty attack. But there's some ways we can try to lower the uric acid level so that way you never get the attack in the first place. And so you can either do that by trying to maintain lower uric acid levels, like trying to decrease alcohol intake, or maybe decreasing use of drugs that can raise uric acid, like diuretics and things like that. But oftentimes we need pharmacologic therapy in order to lower those uric acid levels. And so this is good for people that have like multiple attacks per year. They can utilize this, or if they have a history of chronic kidney disease and things like that. And so we can do it 2 ways, one of which is to decrease synthesis of uric acid, so xanthine oxidase inhibitors, and then we can try to increase uric acid excretion using our uricosurics. So the xanthine oxidase inhibitors, basically, during the breakdown of purines, there's an enzyme called xanthine oxidase that converts some of the precursor molecules like xanthine and hypoxanthine into uric acid. So if you can prevent that from occurring, you get less uric acid. These other products are more water soluble. You just pee them out, no problem. And so these are probably the most widely used drugs for prevention of gouty attacks. So allopurinol being kind of the older of the two, being used all the time. You do want to worry about some of the dermatologic reactions here, things like Stevens-Johnson's and toxic epidermal necrolysis. So watch out for things like rash, blisters, etc. And then febuxostat's a newer one we have here that's probably better tolerated overall. However, you will find that it may be more expensive. So allopurinol's been around for forever. Most people can probably afford that as opposed to febuxostat, but it could depend on insurance coverage and whatnot. In terms of uricosurics, there is a way we can try to pee out more uric acid, but as you might imagine, the risk for nephrolithiasis increases because by increasing the concentrations of uric acid in the renal tubules, you increase risk for precipitation. But we have a drug here called Prednisone. Again, this would be used if they could not tolerate one of the xanthine oxidase inhibitors. And basically, this helps to prevent reabsorption of uric acid so that we eliminate it through the urine more effectively. But do not use this in patients with renal impairment because this can just worsen that and worsen the risk for nephrolithiasis. Interesting that we used to use this to actually increase levels of things like penicillin back before we had synthetic ways of producing it. But you could have elevated levels of certain antibiotics like your cephalosporins, and that could lead to toxicity. But clinically, this doesn't come up that often. And to be honest, I see very little prednisone being used. It's mostly just allopurinol. So, any questions on that? Got done right in the nick of time. If you guys have any questions, please let me know. I don't see anything on the board. Oh, wow, I got a couple on here. Fantastic. Okay. Someone said, I started the video a little late. I apologize. No worries. I'm wondering if someone has ulcers in the rectum, but also in the upper SI or upper LI. Let's see. Would you recommend both PO and PR medications? I think that would depend on the provider and the patient. I would say there have been cases where I've seen both PO and PR medications being administered, but that would be more on a case-by-case basis. That's not the norm, but I have seen that occasionally. So yeah, that could happen. Alyssa was saying, sidebar, my 88-year-old grandma just got diagnosed with gout and she was happy because she feels like she made it. Oh, that's very funny. Sounds like depression era sort of like humor or something like that. Like, oh yeah, I got the gout. I am made in the shade. Moving on up, right? When you go over the diseases, you're just telling us for our understanding in regards to prescriptions, correct? Or will there be questions regarding the disease itself? Right. I don't like quiz you guys on the pathophysiology so much. I do it to make sure you understand the whys of what we do, right? I could make you memorize every single fact on here, but I feel like if you have a background on why we do what we do, or if you understand the pathophysiology, it helps you to understand and intuit how to utilize these drugs effectively, right? So instead of just memorizing a bunch of facts, if you can reason out why we're doing what we're doing, I feel that's easier to do in a test or in a clinical situation than just to memorize the facts, right? So I think of like a real world example. It's just like trying to diagnose, a patient. You can understand, okay, this patient has this history, this past medical condition. It makes it more likely for them to get this other disease state. Why is that? You understand the whys of it, you don't have to memorize it, you just kind of understand it. And so I think that just helps. Probably a bad analogy, but okay. Let's see. Are these medications only masking symptoms by reducing inflammation rather than actually healing the ulcer? In the case of GI, trying to get the context here, but no, by decreasing the inflammation, it will allow that tissue to heal. Like that's why the inflammation is happening, or that's why the injury is happening. It's because you have all this inflammation attacking it. So if you can tamp that down, then it gives the tissue time to relax and sort of heal on its own. So yeah, that can benefit that. See, why would a patient who's receiving methotrexate, a drug used to reduce folic acid, receive folic acid as a supplement? That's a good question. So with folic acid, again, remember that the methotrexate is preventing the recycling of the folic acid. So we'll see there's actually an antidote for that a little bit later on in the oncology section. But basically, it prevents those cells from utilizing the folic acid effectively. So you can't produce any nucleotides and whatnot. So this primarily affects more of the rapidly dividing cells that are constantly producing new DNA, RNA, etc., like your white cells. Okay. By giving supplemental folic acid, the thought is, well, maybe you can help out some of those maybe not so rapidly dividing cells that could be taking a hit here. Maybe it reduces some of the adverse effects. I don't know that there's a clinical study that says you have to do it. It's probably not a bad idea because a lot of people probably don't get enough in their diet anyway. So again, it's one of those things where it's like low risk, maybe low reward, but some people recommend it. So I don't think it's absolutely critical, but maybe it could benefit, and again, little risk for harm. Very good questions. Thank you for asking those. I really appreciate you guys being engaged. What other questions can I answer for you all? Otherwise, you're done. I'm done with it. You can head out for the week. Work on those prescription assignments. It'll be due. The first one's due on the 12th, 11:59. So make sure you get that in. Or if you have questions, make sure you use that hospital-based orders one that is on the second, I think, fourth page or something of the rubric that I attached there. Use that. If it's on the original prescription ones like you would send to CVS or Walgreens, you'll have to redo it. Okay, so don't do that. Any other questions? Otherwise, have a great week. Hopefully the rest of your week goes very well. Stay safe out there, and I will see you guys next time. See any questions? I'm going to go ahead and cut the stream here, but you guys have a good one. I'll see y'all later.